Welcome, everyone. The topic is pretty self-explanatory. We're all aware of the massive demographic change coming our way and the related challenges in healthcare capacity, delivery, productivity. We have a great group of people here. I'm going to start by asking them to introduce themselves, and then we're going to jump right into the topic. So why don't we go in order from me and O'Neill?
Sure. Good afternoon. My name is O'Neill Britton. I'm the Chief Integration Officer and Executive Vice President at Mass General Brigham. I've been in the Mass General Brigham system in one form or the other for the past almost 30 years, and so I bring to you sort of my view from the world of care delivery.
I'm Jeffrey Bundy, a CEO of United Imaging in North America, also 30-ish year veteran of the industry, ran a couple of businesses in the United States, globally, all in the imaging space. So here to talk a little bit about imaging and the role in radiology and the challenges we have there.
Hi, Kris Engskov. I started a company called Rippl about 4 years ago. We take care of patients with dementia and their caregiver and their families and keep them at home and out of the hospital in the ED, a place they end up a lot. And there's probably no better example of what's coming in the silver tsunami than managing dementia, and excited to talk about what can be done.
Hi everyone, my name is Anu Madgavar. I'm a partner at McKinsey, and I lead the McKinsey Global Institute, which is our economics and business research arm. Not directly in the healthcare space, but all my research deals with people, and demographics is a big part of that, so excited to be here today.
Well, actually, we're going to start with you, Anu. So we're going to start with defining and quantifying the magnitude of the challenge. So, Anu, if you can give us a brief, broad brush challenge in the demographics, and then the related potential capacity productivity issue in healthcare specifically.
Yeah. The interesting part about demographics as we started out on the research is that it's all around us, and it comprises so many very individual and personal decisions and experiences that people all over the world go through, whether to have children or not, how to expand the family, how to think about retirement or caring for older people in your family. But what's interesting is that all of these individual decisions tend to be very synchronized and follow sort of these global patterns, and put together, the forces and the effects on our economy and society will be nothing short of tectonic in the coming decades. So why do I say that? It really starts with thinking about how fertility rates have been trending globally. So demographics is not all about too many old people, it's actually about not enough young people, and that goes back to fertility rates for populations, not necessarily in a medical sense, but the average number of children a woman is expected to have in any given country. That's been falling, and today 2/3 of the world live in countries where the average woman is expected to have less than 2 children, which means these are all countries heading for depopulation over time. Their populations will shrink because they're not being replaced. And fertility rates now are down to 1 or below 1 in East Asia, about 1.4 or 1.5 in the US and Western Europe, but even large countries like India have seen fertility rates below replacement at this point. And that means a very massive shift in the age structure of the population. And we in the US and Western Europe are already in that part of the curve, which is a kind of a sharp fall in the share of working age people in total population. That peaked maybe 10 years ago, and it's only falling now, which has 2 or 3 really big implications for our economies. The first is that economic growth will slow down, absent any other changes. We will have fewer people of working age, assuming everything else remains the same. Per capita income growth could reduce by 0.5 to 1 percentage point a year, which is pretty massive for countries which are growing at about 2 or 2.5% at best. The second big implication is that dependency rates are going to rise. Currently, we have about between 3 and 4 younger people sort of available to support older people above 65. That's going to drop to just 2 people in the next 20 years or so. So 2 younger people supporting every older person. And that puts the whole equation of public finances and how to really pay for aging completely out of whack. Think about it as the equivalent of a 10 to 20% tax on all the income earned in the country to pay for the additional needs of retirement, and healthcare is a big part of that. So I think that just frames up the big challenge that faces all of our economies today.
So just a last question on that. Timing-wise, when do you foresee that it's becoming material? I mean, right now we're talking about it, and the system is a bit strained, but it's been strained for different reasons. The margin at AMCs has been, challenging and throughout the entire healthcare system. But when do you think that it's actually becoming a major part of the challenge and becoming material, where in some part of the system you're going to start to see disruption and crisis?
I think the coming 2 decades, and when you think about demographics, it is in decades, it's not in 1 or 2 years, but in the coming 20 years, we will see such profound changes that it will challenge the way we think about our social contract and who pays for whom in our societies. So for example, like I said, in the US today, the cost of the senior gap, which is the gap between how much older people need to spend versus how much they earn in the labor market, that gap's about 25% of total labor income, and that could increase to about 35% in the coming 2 years. That's pretty massive. Think about that as a 10% incremental tax on every taxpayer. Either the money comes through getting more productive or more people working, or in some shape or form getting more efficient about how we pay for and manage retirement. But something's got to give, because in these coming 2 decades, it's really not going to be sustainable unless something changes.
Okay, so let's move now specifically to the impact on care delivery and how the model may need to change. So the good news here is that it's not coming right away. We may have a little bit of time to plan ahead, but O'Neill, maybe starting with a big healthcare system, and I know you guys have been thinking about all kind of different models, going out in the community, becoming more efficient, but how are you thinking about changing the models and productivity on the 10-year horizon?
So it is good news and bad news, because in some ways it's here already. We are constantly stretched and stressed with capacity issues and access issues. And if you're in the market looking for a doctor or trying to get an appointment, especially if you live in the Boston area, despite Boston having the most doctors per capita, it's super hard to get a physician here. So around the rest of the country, I suspect that that is pretty consistent. But one of the interesting things about all the things we just heard is really, when we're doing future projections and trying to guess what the future will behold, it's super hard, because we do those with the known, sort of known knowns that are in existence today. And so I do think that I anticipate that we will have challenges, but how we meet those challenges is still to be figured out. So I'll tell you in the short term that we are actively thinking how to offer more services and expand our workforce. Luckily, as a physician, physicians, because we train so long nowadays, we're in our 30s by the time we're a proper physician, we tend to work into our 60s and 70s. Following the old adage of most people work about 40, 45 years. So physicians, we have a lot of physicians who continue to work, and we try to make the environment hospitable to those folks, that they continue to enjoy their careers. But even with that, there continues to be a shortage. So how are we meeting that? So we have had the rise of the APPs, the sort of advanced practicing providers, whether those are NPs or PAs, and they continue to churn out many, many capable professionals. And I think us meeting the demand in the future will be somewhat dependent on continued sort of production of APPs to balance out the physician workforce. In addition, I think most health systems are exploring a transition to health teams, not necessarily a physician or an APP being involved in every decision, but how do we surround the patients with a team with a mixture of nurses, APPs, physicians, and lay people who can check in, what we call care navigators, people who can do everyday things that don't necessarily need a licensed clinician to answer, and really pivoting more from a curative sort of how do we help people after something happens to how do we prevent things from happening. And so there is much more of a lean into the sort of preventative methodology. And the care models are evolving. So I sort of, my day-to-day work is to really balance out a health system that has healthy components of acute care hospitalization, that has care that can be delivered in the home. So how do we leverage patients and families who are sick but have capable help at home, so we offload the demand on the acute care hospitals. And then you have other things such as urgent care, emergency care, of course, primary care, one of the big challenges we have going forward, and we're thinking through how to balance that. And then you have what I call retail care. At my hospital, Mass General and the Brigham are two AMCs. I always make the joke that if a patient comes in and gets a vaccine at one of our hospitals, we have failed, because we should not be given vaccines ever. That needs to be done at some retail space. And that is an easy thing that avoids the congestion and the sort of challenges that patients face as they try to access care. So I think across those domains, we're looking at exploring all those things. But the last thing that I'll throw out there that is the big unknowns is how technology enabled will become. So how much will patients be able to do for themselves? We used to have the adage of Dr. Google, but we're going to go into the Dr. ChatGPT fairly quickly. And how quickly will that adoption occur? And then getting back to the workforce, because Anu is right, there is a math. If people are having kids and a lot of people are getting old, the math is not there. So will Mr. Musk come through with his robots? And how much will robotics and homes that are enabled to take care of people in homes and in situations, how quickly does that rise in the next 10 to 20 years? And, you know, I will say that I've been impressed with the massive advances that I've seen in the AI space. And I think, you know, when people talk about robots, maybe 30 years ago, we'd scoff, but I think it's pretty real, and whether some of the workforce, at least around the manual things, even around the productivity, farming, you know, manufacturing, how do we adjust, and will there be more people freed up from the workforce to do other work and provide direct care? Because all these people who are being replaced by robotics will have to do something to earn a living, and then would that sort of play a role in the expense side, which you know, sort of allows us to avoid, for a time being anyway, the tax increases that you're worried about. But that's how I'd summarize it.
So, O'Neill, a brief follow-on question. As you guys obviously are thinking through all those different models across the system, all the way from the EMC to the satellite and going in the community, is there some ways to model productivity forward? Are you guys already trying to quantify how much more capacity, whether it's, you know, not necessarily brick and mortar and headcount, but through all the different innovative things that you're trying to do, how do you predict and model increase in productivity?
Yeah, so that's a great question, and we are looking at that. We're looking at it from the perspective of decision making, you know, so how do we use tech to increase rapid cycle decision making, even in day-to-day care? And so whether that offers some efficiencies as we move forward. But we're also actually looking at our own capacity, because sometimes people will say we're full, and full is different for everyone. We have found that there is wide variation in what people mean when they say we're full. And so there are innate capacity that we're working to free up in terms of the brick and mortar and the staffing of the brick and mortar. And quite frankly, you'll hear from my colleagues about imaging and other things, but one of the things that we started doing and experimenting and has worked out fairly fantastically was, for instance, expanding the hours of imaging. And so we started experimenting at first and saying imaging started at 8 o'clock, and then we moved it to 7, and then somebody said, what if we moved it to 5 a.m.? Would patients show up? And we moved it to 5 a.m., and all the slots were taken immediately. Apparently, patients want to show up for imaging before they go to work and just get it out of the way. And so then we started to work on the back end. And we said, what if we moved it past 5 p.m., then 7 p.m., still full, 9 p.m., still full, 11 p.m., still full. And so we now image from 5:30 a.m., 5:30 a.m. till about 11 p.m. We tried 24 hours to see if there are some sleepwalkers out there. And that didn't work. So patients trailed off after like midnight, and then they'd come back at 5 a.m. And so, but we tried everything, and that's some of the innate capacity that we're working on, and just being a little bit more forthright about the 24/7 hospital and 24/7 acute care, and how much can we get out of the capacity that we have today.
So now I can help it. One last quick question. So it's a bit worrisome that you didn't find the limit of demand, or at least you did in the middle of the night, but otherwise everything else filled up right away, which is not great news.
Yes. And it's interesting because even when we try to do it at night in the hospitals, the nurses get nervous about moving the patients. And the patients also complain about noise at night. Yes. So there are always these sort of trade-offs and sweet spots you're trying to curate and find. But we try to find a balance, and there are always people who will be a little bit more adventurous. But I think everything that was stated will remain challenging, and again, I do hope that the technology piece does bring some respite.
So we're going to stay in care delivery, and so Kris, maybe tell us a little bit about Rippl, and then let's take dementia as obviously a very important component of aging, where presumably care delivery is going to have to massively increase productivity to address the coming wave.
Well, I hope it does, or we're going to be in big trouble.
Yeah.
I'll say this: I don't think we like old people very much in America. If I can just be provocative, or we would have far better care, because I was listening to my colleagues here talk about the realities of what's coming in, and there's no better example of that than actually dementia. I mean, everybody talks about the coming silver tsunami coming. We are waist deep in it right now, and we are still vastly underprepared for what's coming after it. So I used to run a large assisted living company, and I was stunned by the number of times we would send our residents to the ED in the hospital. We were the people who were supposed to be keeping them at home, right, in their home. And I discovered in trying to solve that problem that in our case, almost all of that was related to dementia. And that actually led me to start this company because we have a huge need to be able to keep seniors with these chronic conditions, specifically dementia, at home for long periods of time. That's our only choice. There isn't enough. Everybody always tells me, oh, I'll just put my mom in a facility. Well, you probably won't, because most people in America will never afford one. And secondly, there's not even remotely enough supply of that, with 75 million, seniors coming our way. So we got to get really smart about using technology, better clinical care models. So, I'll just use us as an example. I think, COVID obviously opened up the opportunity for telehealth and the promise of telehealth. And today, we deal with seniors with dementia. We have a clinical care model that wraps around that patient and caregiver, and again, keeps them at home. And people ask me all the time, isn't it hard to get someone who's 85 and demented to use technology? And remarkably, that's been the least of our problems. Lots of problem solving to do, but this is someone I think said this morning, a very tech savvy group of patients and frankly, caregivers. So I think there are lots of opportunities to keep people at home better. I think a lot of it will come down to working with more creative ways with payers and health systems and others who own the risk, right? It's players like us who are innovative and willing to go out and find new ways to finance this care and share that risk with you, because we are confident that we can do it. And that's exactly what's happening. So value-based models get, I think depending on who you're talking to, we got to get there, but there's real practical things happening right now, particularly in dementia, that we can create new swim lanes to value. The last thing I'm going to say, and I'll be quiet, because I agree with almost everything everybody said up here, is we don't, in addition to not liking old people very much and investing in them, particularly those we think that may not have much of a future, and yet that's quite the opposite with dementia. People live for a long time with this disease and contribute in a big way. We're very passionate about that and hope you can feel it from me. But we got to get very serious about caregivers. They're the ones, at least in our case, that pull the trigger to go to the ED or to the hospital. And yet we sort of ignore them. Remarkable statistic, I'm sure you know this far better than I do, 60% of working adults are also caregivers right now. That is a remarkable thing. And I tell employers all the time that if you talk about something that can mess with our macroeconomy in a huge way, if you're going to work every day and you're worried that your mother is going to go walk out into a highway, that's the one thing that's going to keep you from going to work, maybe besides your kids. So we've got to really get models in place that embrace the caregiver as a central component, profound component of, keeping people at home and, seniors specifically. I think I'll stop there.
No, you can be quiet yet. I have one more question, but so one important aspect here is, when all of us were talking about healthcare cost, solutions were supposed to come in part from the private sector, right, where government was very slow and clumsy, and then what we've seen so far is that the costs have been more additives than subtractive, which has not really been helpful. Now, that being said, some of those solutions are probably very good. Over time, you would hope that they will actually save cost and increase productivity. But in terms of adoption, how do you integrate with the current system of care, right? So is that a competition? Like, do you have some traditional system, whether AMC or maybe even the payer saying, well, I like your solution, but or you compete on price, or any other. I'm just thinking about what are the variables of adoption and competition, because that's a very interesting aspect.
Well, in dementia care, there's not much competition because there's no infrastructure, right? We set out to build a national infrastructure, a clinical infrastructure to wrap around these families and again, keep these seniors at home. And oddly, our competition today is really PCPs who don't want to be competition at all. PCPs really carry the water for dementia because, and I'm going to say this because every time I say it, it sounds very dramatic, but what I realized in building this company, there is nobody in America who knows anything about dementia, which seems impossible, and yet it's entirely true, mainly because we have just never, ever paid for it. So I would say primary care is our primary competition, and yet they're not our competition at all. We integrate with them, we work closely with primary care docs, really to extend their capability, because they want the best for these patients. They're typically, at least in dementia, not super knowledgeable. There are no great answers, there are no cures today, so there's not a lot they can do, and they're very happy to hand it over to us to really help manage that patient and their family, and answer all those questions that they may not have time to answer in that 15 minutes they have. The other thing I would say is just also, I think as dementia gets speed here, because I'm glad we're talking about dementia. I'm obviously passionate about this, but it is going to be overwhelming to our health system very soon. Not only because it exacerbates other comorbidities that people have. There's about a 30% exacerbation to cost when you have dementia alongside CKD or some other chronic disease. But also, we're going to have to be much, much smarter about how we take risk with payers and providers. I think that's the bigger competition we have, is not competitor to competitor, but finding creative ways to actually make caring for these people make sense for everybody. And they exist, but we got to be pretty innovative.
So, okay, so we'll come back to the care delivery, and but let's get into technology. So, Jeffrey, maybe tell us a little bit about what you guys are doing, and then if you can kind of focus on the technology and how it's enabling some of the models that you guys are deploying.
Sure. Thanks for having me here. It's this is like very interesting to be like an intersection of my personal life and my business life, because I'm one of the last baby boomers, so I'm a part of the one side of the dementia problem. I talk every day with customers who have workforce challenges, and we just lost my mother-in-law to Alzheimer's a couple days ago. So And what I see, you know, this tsunami that's there, and you mentioned it as well, Neil, is it's here already. It's not something that's coming. We see the challenges. We hire from similar talent pools that you guys do, so we have the same challenges of finding people available already today. Not forget the future demand. That's already a problem. And not only on top of just the demographic portion, we have the whole area in our business in imaging. There's increased demand for imaging, for diagnosis, finding the right treatment. I mean, all that stuff is a multiplier on top of the people that are coming and the wave of numbers of people are going to need these things. There's all kinds of new places where imaging is going to be needed. My company we are a medical imaging equipment manufacturer, very vertically integrated, that has a huge AI component of what we do, and we have future modalities coming out. Also in looking at wearables, all kinds of areas in the home health area. And so looking at the entire continuum of care from what happens in an academic medical center to what happens to where I now live in a place like Southern Indiana, where I have a bigger problem than you do because I just go to urgent care because I can't find another appointment. It's impossible, especially when you move into a new place and you don't have an existing care physician. So all these things are personal. The company was founded, we're about 14 years old. Headquarters are in Shanghai. Our US headquarters and manufacturing for US customers is in Houston. So that's where my office is, in Houston. Was founded really on healthcare inequity. So one of our mottos is equal healthcare for all. And we believe that no matter the zip code of your birth or the zip code of where you currently live, you should get the same healthcare. I've been in academic medicine since the 90s and worked a lot on collaboration and how do we bring new technologies to market. But when you live in different places around the world, you find that not all that stuff makes it there. So I think technology is one thing. There's a lot of things that we can come back to that, maybe on automation. There's a lot of AI automation. Whenever we have these conversations, we're always talking about workforce issues, but we're also talking about how AI can solve all of our problems, and hopefully it can. But it certainly is on the agenda everywhere we talk about it. But I do think there's a business model aspect of this that is really important, and because we have to pay for everything, things have to become affordable, and you can't just push the pressure of productivity and ask people to work another extra hour shift or to work an extra day a week to solve the problem. So we have to figure out how do we do that. And on top of that, the older I get, the less I want to go somewhere. And the harder it was to get my mother-in-law to go for treatment out of her community. So how do we get the same care that someone can get and come and find a parking garage and find their way through all the hallways to the imaging facility in downtown Boston versus staying out, and I don't know the suburbs. I know Burlington, that's where we have an office. So somebody in Burlington, how do they get the care and don't have to not only get their vaccine, but how do they get the same care from an MRI suite? And one of the things that we do, our business model is that everything that we make, every software that we make, comes on the system initially, and in terms of the longevity of the system while we have a service agreement in place, everything gets updated forever. So no matter whether you buy it in Boston or Burlington, or I always say Manhattan or Manhattan, New York, or Manhattan, Kansas, you're gonna get the latest, greatest things. And in order to do that, there's a lot of other problems we have to solve for, which we were talking about before. Not only how do you bring the latest, greatest technologies, because if we believe in that zip code thing I just said, then everybody ought to get the latest, greatest, best things. But then how do we get to the workforce? How do we get people out in those areas to be able to scan and be able to run the systems at the same level as an academic center, which we're working on those things too, but I'll stop right there.
So maybe, and in no particular order, but maybe going back to you, Anu, we've been talking about all those potential solutions, new models, technology. Obviously, everybody hopes that AI is going to be very helpful in productivity, but the other question is the unit cost. Is that, we're going to try to increase capacity to meet that increased demand, but financially the system is already on the brink. So not only do we have to increase capacity, productivity, and implicitly, as a basic economist, if you increase productivity, unit cost should go down, but it has not really been the case in healthcare. And so as we implement all those new solutions and you have potentially different entities not competing but taking care of one part of the problem, unit cost may actually be very challenging. You might be increasing capacity, but unit cost is not being addressed, and then we have a huge financial problem. So can we talk a little bit about unit cost, just not technology and new models, but thinking about as we increase capacity or output, how do we think about unit cost?
I think unit cost is a really interesting question, and it's a little bit different from questions around pricing or who pays. Yeah. So we should separate the questions, right? But in its essence, unit cost is a function of productivity. And by productivity, I mean being able to either do more with existing resources, handle more patients, perform more procedures, whatever's required, achieve better health outcomes with existing resources, or of course, reduce the amount of resources that you need to deploy for the current level of output. So the second option is not really relevant for all the reasons Jeff talked about. We will have not only more older people, but more older people living longer, and then the intensity of diagnostics and care are multiplying. And then as Kris said, which I found fascinating actually as a perspective, we often talk about automation of work, but all of that is sort of the paid work in the paid economy. And people like me and researchers are constantly saying, okay, what do workers do and how can that be automated? There's also the unpaid world of work, which has tremendous automation potential and benefit in terms of greater leisure, or more likely, people being able to focus more on paid work, right? So if you think about the post-World War II technology phenomenon, a lot of women came into the workforce, and that went along with all the household appliances and white goods and all of that, automating what was manual work earlier, right? And that has huge unit cost implications and output implications in the real world. So I think all of these things need to come together. What we have seen, what I can say is that when we think about all of these healthcare and medical services, there's a cognitive work component, and then there's a physical work component, right? So cognitive is stuff that you have to think about. Physical is stuff that you have to move or do in a very physical sense. In general, the unit costs of cognitive automation are lower. The integration timelines are quicker. The solution development is also faster. And so we expect to see more automation in the cognitive world. The physical world is more challenging, and technology development, integration, deployment needs much more sort of thinking about, well, what's the real cost? Is it cost effective to have that robot to help my grandmother walk every day? At some point it will be, but until it is, I can't really think about it. I need like maybe a real world helper, right, to be able to do that. So I think unit cost is complicated, but this drive towards saying, how can we really increase productivity? And according to our surveys of the industry, I think McKinsey had surveyed about 150 healthcare leaders across all segments of the market. It seems like universally people are thinking about not just, or actually doing, not just pilots, but also starting to have implementation at scale of various AI solutions. But we are at a very early stage of actually seeing the productivity and the unit cost revolution that could come out of it. So think about it, I think about it as today is almost the worst version of the future world, because a lot of this will come to bear fruit, I guess, in the coming years.
So maybe O'Neill, not to put you on the spot, but you're running the largest organization here on the panel, or you're in charge of the largest organization. How are you guys thinking about that? Is that part of the strategy planning and thinking about unit cost, even if it's not across the entire system or all the component, but at least piece by piece? Oh, sorry. Yeah, I was just asking O'Neill to talk about unit cost in the context of a large healthcare organization, and whether there is forward planning or it's part of the strategic planning.
Well, there's definitely forward planning around unit cost and trying to figure out how to be as low cost as possible. But it is, as you mentioned, Anu, there is the today's challenge, which is very high unit cost, expense-driven manual processes with a relentless demand, which it's stated in the title. And how do we try to meet that challenge while planning for the future? So there is a little bit of holding two things together, where we're managing day-to-day challenges and operation challenges in meeting the needs of our patients, while also thinking through how to reorganize ourselves or how to work differently, either through teamwork or alternative work or new ways of working from a workflow perspective, that would allow us to be better in the future and potentially lower that global unit cost. So those two things are two active spaces that we always think about. I agree with Anu too that we would welcome technology, but it is not there yet. And what I was alluding to earlier, however, is that the apparent pace at which it changes looks like it's about to accelerate. So how that plays out is an unknown, but we're hoping that it plays out positively on our behalf. But nevertheless, like everybody else, we have the day-to-day, today's challenge of trying to meet the needs of our patients.
So Jeff and/or Kris, maybe start with Jeffrey. Are you, you're offering a new technology-enabled service to address a big chunk of what's needed, i.e. imaging. Are you, so what, and don't tell us what you can tell us, but are you competing on cost? I mean, what is the discussion when you go to a healthcare system or a hospital and you're offering your solution? Surely you must be talking about what are the implications in the midterm, maybe long term, given the issue we're talking about.
No, I think one of the things at the basis of our solution is to make sure that what you have today isn't state of the art in 5 years. And that's the business model change, which I think is not really a part of our industry, which we are bringing to the industry. So the other pillar that we stand on is being an innovation leader. And we have a huge investment. We have 1,200 AI engineers based in Shanghai and in Burlington, Mass, a much larger group overseas. But a lot of that focus is on how do we remove those not reimbursed tasks? How do we take things off the physicians or technologists that are not getting paid to do? Automating scans, making scanners autonomous, taking out steps, predicting what's next, and before, once you know the technology is going to do next, then just do it for them. Don't wait for that to come. Those are big parts of it. We're working on remote scanning, which takes the technology from an academic medical center out to another location. But I do think the big focus of our AI needs to be on taking away things that are wasted time and effort. Another example is a radiologist sits in a reading room and they're integrators of information. They're not just, as we heard in the last session, not just looking at images, they're integrating a lot of information. How do we get all that information to them without having them to get on a phone or call someone or ask for the information? We're building systems that are predictive. When you bring in a CT and there are prior CTs, then fetch those prior CTs. If there's related data based on the diagnosis, bring that in front of the radiologist together, and that way that they can get all the information they need as fast as possible, move on to the next patient.
So, Kris, you get the last word implicitly, because we have 1 minute, but like just talking about cost, and again, don't say what you can say, but how do you address adoption as you go head to head maybe with other type of delivery model?
Well, I'm gonna maybe go a different direction. I mean, we have a big topic here, so I feel like I can go anywhere I want. But I would just say the one thing that I don't think we've talked enough about that I think is critical here is technology is going to make a big difference in taking, unproductive work out of the workflow. But we still, I'm an optimist about technology, and at the same time, I'm very confident that for the next 25 years, we're going to have hands-on with a lot of seniors. They're going to expect us to have people. And, the combination of those two things are going to be important. But for me, the biggest problem we've got right now is actually making this industry attractive to young people. I tell my 15-year-old daughter all the time, I said, you better like old people because that is what you are going to do with your career. most likely. And I think we have done a really bad job at making this a sexy industry, right? Not just, I think the Pit won a bunch of awards last night. Okay, so that's the ER, always very exciting and glamorous. But what about actually putting hands on a dementia patient every day, right? Really getting people attracted and passionate about how they can change lives in this industry. And I think we're falling down on that right now. The other thing I think that we got a big opportunity to do is just get better training. And we did something, I started my company 4 years ago, and the very first thing I did was go to McLean Hospital because I was convinced they probably knew more about dementia than any other place in the country. And I was right. And we actually worked with them to build a cutting-edge training program, selfishly for our company. But it's pretty remarkable to think today that a care navigator working for Rippl, living in Graham, Washington, a little town outside of Seattle, sitting in her bedroom at her desk, has access to the very best cutting-edge training around dementia anywhere in the world from McLean Hospital, at her desk, in her bedroom. I think that's the opportunity we can give people, especially in these telehealth models. And we just got to create a better culture in healthcare to attract a much, much more active group who's, ultimately going to have to embrace that this is what they're going to do. So I knew not where I was supposed to go, but I'll add that.
Great last words. So thank you all. Great panel, and I hope you enjoyed it, and we're out of time.
Thank you.